Hello, I'm hematologist-oncologist Dr. Tony Talebi. We're back with Dr. Ann Moorbacher, Associate Professor of Medicine at University of Southern California, and now we're going to discuss the management of stage 1 and 2 diffuse large B-cell lymphoma. Thank you for being here.
Sure.
Okay. Let's assume a patient has had an excisional biopsy of a lymph node that has come back positive for diffuse large B-cell lymphoma. How would you know if it's stage 1 and 2, and what happens next for that patient?
Okay. Well, first we assume that the patient will go through the standard staging tests, which are body CT scans of neck, chest, abdomen, pelvis, usually done with PET scan if they already know the type of lymphoma is diffuse large B-cell lymphoma. And that's to make sure that they measure and evaluate any lymph nodes in the region and unsuspected areas elsewhere in the body. PET scan being a little better for highlighting areas that might not have occurred in lymph nodes, that might have been overlooked on CT scan in the bone, for example, or GI tract. If it's confirmed that it's stage 1 or 2, to really be confirmed, it does require having a bone marrow biopsy, because bone marrow can be involved without any clinical symptoms, without any evidence on blood tests, and if it is evident there, that would change that patient's stage to stage 4, would change the management quite significantly. Most patients with diffuse large B-cell lymphoma are not stage 1, but stage 1 patients are treated differently from all the others. Even stage 2 these days is generally lumped with the stage 3 and 4s in terms of management. But there's a potential to consider alternatives to just the full course of chemotherapy in a stage 1 patient, such as radiation, or a combination of chemotherapy followed by radiation.
So if you were to consider that, how many cycles of chemotherapy would you give? What chemotherapy would you give first of all?
Okay. Generally, we'll still use R-CHOP chemotherapy as we would for the classic stage 2, 3, or 4 patients, because that is shown to have such effective curative outcomes in those more advanced stages of diffuse large B-cell lymphoma. Very long ago, they would take a stage 1 patient and just do radiation, and the cure rate wasn't too bad. It was about 50%, but we know that there's often more than meets the eye with stage 1. We don't see other sites of lymph nodes, but those cells are blood cells. They're free to travel, and there's always a possibility that they've already made their way outside of the visible lumps and bumps we see on CAT scans. So many years ago already, it became clear that you probably should treat with chemotherapy first, even if you're going to rely on radiation for that regional area. And the thought was to give 3 cycles of chemotherapy. This was back in the era before rituximab was available, so it was done in a large SWOG trial, Southwest Oncology Group, with 3 cycles of CHOP chemotherapy followed by radiation therapy. Versus continuing a standard course of chemotherapy, which at that time was usually more like 8 cycles. These days would be worth 6 without Rituxan. So at that time, it seemed fairly equivalent to use a shorter course of chemotherapy and finish with radiation. Perhaps over much longer follow-up, out to 10 years, there probably was a slight lead for doing the longer chemotherapy. But what also changed since that was reevaluated was that rituximab was added to the regimens, and that alone increased the curative potential. So the question has come back to, is there much advantage to shortening the chemo and doing radiation? In some areas of the body, that would be much simpler, where there's low toxicity to radiation, such as the armpit or the groin area. You could simply do a shorter course and finish with radiation. Other areas like head and neck, in fact, most radiation oncologists feel that because the area has a lot of collateral blood supply, they really ought to radiate the whole, mouth and neck area, and that leads to permanent dry mouth for most patients. So it's also an option in a stage 1 to just continue the chemo. The toxicity is relatively low for most patients if they're tolerating it well. It's an option not to do the radiation. These days, most people do 6 cycles. The French have looked as little as 4 cycles of R-CHOP, and the outcomes look quite good. Cure rates are very high in stage 1, probably better than 90%.
I see. So let's just break this down. What is R-CHOP? What is every single chemotherapy in R-CHOP?
Okay, so the CHOP part has been around for decades. It's Cytotoxin, Adriamycin, vincristine, and prednisone. You might say, why does that add up to CHOP? Well, it's just the chemical brand or generic names of those drugs, but the name stuck, CHOP. Rituxan is a monoclonal antibody, not a chemotherapy agent, that's directed against CD20, which is a marker on the surface of virtually all mature B cells and allows the immune system to target and kill those cells. It also has its own direct actions when it binds the cells that help synergize with the chemotherapy. So no one would treat diffuse large B-cell alone with Rituxan, except maybe in a very, very, very elderly patient who couldn't tolerate chemo. But when they put it together with chemo, it clearly enhances the cure rate of chemo in a more than additive way.
What are these side effects of Rituxan?
Rituxan, as an immunologic agent, has side effects that fit more with immune system reactions, like flu-like symptoms. On the first day people receive it, they sometimes will have a shaking chill, like a big shiver, or a fever, or even some hives or a little shortness of breath, as if they were having an allergic reaction. It's not a true allergic reaction. They can actually stop, remedicate with some allergy-type medicine, steroid and Benadryl-type drugs, and restart it at a slower rate and usually finish that day. Occasionally people have very severe reactions and have to even take it broken up over a few days or overnight if they happen to be in the hospital.
What about Cytotoxin? What are the side effects of Cytotoxin?
Well, the entire list is quite long, but the predominant list is that the drug is a classic chemotherapy agent. It kills fast-growing cells, including normal fast-growing cells of our hair. It will cause some hair loss a little less abruptly than the other drug in the regimen, Adriamycin. It will lower the white counts at the midpoint of the cycle, usually between day 8 and 10 after the chemotherapy day. And it can, in certain individuals, cause nausea or mouth sores or irritation of the bladder and so on. Generally at these doses, those are fairly minimal, and the nausea is easily prevented with standard anti-nausea medicines today.
What about the Adriamycin?
The Adriamycin or doxorubicin is, again, a classic chemotherapy drug. It is the drug that is known to add the cure potential to the regimen of CHOP. That is a little notorious for causing abrupt and very complete hair loss. Never seen a case where it was prevented by any maneuver we know of at about 3 weeks after they've been exposed to it. It is also one where we have to take a little caution to check the patient's heart function before they receive it, because in patients with underlying heart pump function or some vulnerability to that, this drug in cumulative doses can slightly decrease pump efficiency with heart. It sometimes causes a little dark mark on the nails that grows out, and can cause a skin burn if it leaks, so they're always very cautious with the IVs, making sure that the IV site looks good, because it's very irritating if it leaks out of skin. It enhances the nausea or low white counts that you'd see with the Cytoxin, but again, it's very predictable, very understandable when those counts will fall and when they'll come back up.
What about the vincristine?
That drug is relatively mild from a medical point of view. It does not usually cause low blood counts. But it can cause very dramatic constipation in some individuals. It's usually minor constipation in the average person that they can get over in a couple days. And with cumulative doses, particularly if it's given at a shorter frequency schedule, can cause numbness or tingling in the hands or feet, very commonly in the fingertips and sometimes in the feet as well. That goes away usually with time. Patients will see over several months after they've done the chemotherapy, that effect tends to wear off.
What about the prednisone?
That's a classic steroid of the glucocorticoid or anti-inflammatory class, not the weight builder type, and is used, in asthma and rheumatoid arthritis and other autoimmune diseases to treat them, even bad cases of poison ivy. But it's given in high doses for a very short time, 5 days, 4 or 5 days, with the CHOP regimen. During that time, people who have a tendency to diabetes or fluid retention or high blood pressure sometimes see a little upswing in those things, or they didn't know they had a diabetic tendency, and the prednisone sort of brings that out and their blood sugars go up or off the wall if they're already diabetic. But they come down as soon as the prednisone's out of the system in most cases. Some people feel very pleasantly energetic on it, like they've had a little espresso. Other people feel a little too wired, or even people who are a little on the margin might feel psychotic on it. That's been seen, not very common. Your average person isn't going to have to worry about that. More commonly, people just have a little trouble sleeping because it's keeping them awake.
Can patients exercise while they're receiving chemotherapy?
Certainly. It's even recommended if they have the energy to do that, both because it's good for people's stress levels to exercise, and we like people to try to continue their normal lifestyle as much as they feel they can while they're on chemotherapy. I'd say most of my younger to middle-aged patients on our CHOP are able to even work full-time if they wish to. They don't find it that difficult, but I don't want to make people feel that they have to expect that. Some people do feel unwell on it and will need to take disability. Older patients vary. Some of them will have no problem with it whatsoever, and other folks will feel quite tired on the chemotherapy and really have to take it easy. Exercise is always allowed as much as a patient feels, energetic enough to do it.
What will happen to a woman's menstruation while receiving chemotherapy?
Generally, that'll be a little dependent on the woman's age in terms of, how strongly her cycles will continue into it. Most women will taper off in terms of having visible menstruation while they're on CHOP because just the anti-proliferative effect of the chemo will slow down the uterine lining. But there is also some direct effects on ovarian function. So this is a chemo regimen because of the alkylator drug in it, Cytotoxin, where we would have to warn women that there would be a distinct possibility of infertility or early menopause after the drug regimen. There are not yet perfectly defined ways to prevent that because, for example, in a woman in her 20s, her ovaries might just have enough extra reserve that when the chemo regimen is done that they go back into active phase, but a woman in her 30s or 40s would very likely shut down for good after that regimen. And as you know, the fertility options are a little more murky with women in terms of how effective or useful they are. This is an aggressive malignancy, so we're not usually very comfortable taking much in the way of long delays and initiating the chemotherapy to do fertility treatments, which are often on the order of weeks to a month and a half. And we often can't wait that long. It's a little easier for males because they can sperm bank and that doesn't delay their chemo more than a few days. And even then, we've had some men who've had extremely aggressive bad complications of diffuse large B-cell lymphoma, and it wasn't even safe to wait those few days to do that.
I see. Well, and what about sexual relations with a partner? What are your recommendations on that while receiving chemotherapy?
Well, generally they're not discouraged. There's probably not much in the way of any medical harm. Maybe some concern for infections. If someone's white counts were extremely low for long periods, more than a couple days, some people would recommend using condom just to prevent any issues of maybe germs being swapped and so on. But most people, with their partner, live with that person, are used to each other's germs. It's not a huge issue. A lot of people are just going to feel a little tired. That's not the highest thing on their agenda, but we certainly don't say that they shouldn't. One question would be that we'd strongly recommend birth control while on the regimen, even though the periods might stop or the sperm count might go down. We don't know when and that will happen, and it would probably be very unwise to get pregnant or get someone pregnant on it. Not even necessarily that it would transmit genetic damage to the fetus, but that it'd be very hard to go through a pregnancy and interrupt this chemo. It's probably not good for a baby to be on chemo. It's been done. We'd hate to be in that situation if we don't need to be. So we suggest people use barrier methods of contraception, even if they're already, using the pill or other forms.
How do you deal with depression in your patients?
That's always a big issue in all cancers. It's a very life-changing situation, and even people who wouldn't normally be very prone to depression, this might be the one time in their life where they feel that way. There's uncertainty. We try to reassure most people with diffuse large B-cell lymphoma that the picture's fairly bright. The cure rates are quite high. There are a few subsets of them, though, are very difficult to treat or cure. And so I would say because it's a manageable situation, a lot of that support comes right from their doctor and the nurses treating them. They have time to sort of have some discussion of what does this mean for my life, what's my prognosis, will I need to stop work. One thing I tend to recommend, if patients already tend to lean a little in the depressive direction, and they're hesitant about using an antidepressant, to realize that this is a temporary but tough situation and not to be too resistant to using antidepressants if they need it during that time. They are helpful. Even though you say the cause of your depression, they still are helpful in that situation, and I encourage people to use them and say, you'll likely be able to go off them later. They don't harm in any way your ability to tolerate the chemotherapy, and I think are often helpful. I also do suggest that people do exercise, go to work if they feel well enough to go to work, do the things they normally do, because the regimens used here are not usually so prohibitively difficult that they can't. And it's hard to just sit home and worry about how you feel or what might happen in the future. In some ways, having the natural support of going to work and seeing other adults and having your regular lifestyle, I think, is helpful.
What about the use of alternative herbal medicines during chemotherapy? What are your thoughts on that?
Generally, we try to ask people to take a break from anything like that during the chemotherapy itself. The body has to metabolize and handle everything that comes in: food, alcohol, herbal medicines, even teas, that, green tea that we normally think is good. We just sort of don't want anything that's excessively taxing your liver or your body's need to metabolize it. In fact, some good things like antioxidants might work a little bit against how a chemotherapy agent is working in those cancer cells. They create free radicals in the cancer cells, and you don't want to give them a rescue from that with antioxidants. So we particularly ask people not to take anything higher than a regular multivitamin. We don't particularly recommend multivitamins while they're on it, but we don't forbid people to take them, because we don't want to do anything that would oppose the action of the chemotherapy. Remember, the rest of your body has good repair mechanisms and will usually recover itself from the chemotherapy much better than the cancer cells were, and we're relying on that advantage to safely get away with giving the chemo. Once people are done, if they would like to use those things, we don't forbid them. We don't know too many of them that are specifically helpful. We'd like people to focus more on a generally healthy lifestyle after they're cancer survivors, and that healthy lifestyle is based more on things like exercise and a healthy diet of whole foods, not particular supplements or vitamin this or herb that.
Right, true. There is a small possibility that the chemotherapy might cause leukemia down the line. What do you tell your patients about that?
Generally, that risk has been recognized not only secondary to lymphoma treatments, probably a little more dramatically after breast cancer treatments. Two of the drugs overlap, Cytotoxin and doxorubicin or Adriamycin. And I've wondered about that, whether because very often a woman who's had breast cancer also has needed radiation to the breast, whether there's some interaction there. In the days back when we used to commonly do radiation with CHOP chemotherapy, we probably saw a little more incidence of that combined modality therapy in Hodgkin's and non-Hodgkin's lymphoma and breast cancer, have probably created a little bit of a 1-2 hit to the genes of certain cells, of the stem cells of the blood system that might evolve into leukemia or cause bone marrow failure, which is called myelodysplastic syndrome. It seems, I don't know if anyone's really gone back and reevaluated the incidence. They used to estimate as high as 5%, but I think they're including the breast cancer patients in that. And I wonder if we looked back in just the last 10 years, whether this is as true. Because I was trying to think the other day if I could remember a recent case of anybody who had had lymphoma and a secondary leukemia. I've seen several breast cancer cases.
Breast cancer is true.
Yeah. The same drugs that would be putting them at risk. The Cytotoxin predominantly, and to a lesser extent the Adriamycin. Much lesser risk from the Adriamycin. But I haven't seen many of those cases in the last 10 years, and I wonder if we're doing something else that's modifying that, like using less radiation.
I see. So let's talk about radiation. Let's say someone does need radiation. How does that work? How many times do they need to come?
Okay. So radiation therapy these days would generally be done for patients who had a stage 1 and decided they're going to do the shorter chemotherapy finished with radiation. It's quite safe to do in certain parts of the body. Like I said, under the arm and the groin area, there's not a lot of other structures that will be injured by radiation. Think twice about it in big areas that are central to the body. The other area where we might use it is in a patient at a very, very large mass, more than 10 centimeters or 4 inches. And even that's being modified a little bit these days. Someone's a quick responder to chemo. We've debated, would it be better to just wait and see? You could always go to a transplant if it did come back. And, although that's more elaborate, a lot of people would never have it come back. But the radiation itself is actually fairly easy to most patients relative to chemotherapy, because the radiation doses you use in lymphoma are not as high as you see in other cancers. Lymphoma is very sensitive to radiation, so usually we're in the 3,000 to 4,000 rad range, and that often is not that tough on structures. But they go daily for about a 10-minute course of radiation. It doesn't hurt, doesn't feel like anything while they're in that room. The setup to plan the radiation is often the longest and the most laborious day, the day you have simulation, as they call it. They're modeling where your lymphoma is and where they need to make that radiation field. And in some cases, if a lymphoma is in a tricky area that's sort of too close to the heart or near the spine, they'll do some rather fancy computer modeling to make that more sort of designer radiation so that they don't damage things around it. Again, in diffuse large B-cell lymphoma, since radiation is usually following chemotherapy, they don't need to go to very big doses, and they don't usually need to do a very extended area because the chemo has already cleaned up the surrounding areas. So it's commonly going to be in the sort of 3-4 week range, and sometimes another week or two of a boost. Just a short 10 minutes every day, weekday, to finish that course.
What side effects do they typically experience, the patients?
Well, if it's in the mediastinum, in the center of the chest, that's where a lot of lymphomas occur. If they had a big tumor that they feel really ought to be finished or treated or consolidated with radiation in the end, the esophagus runs behind it. And esophagus is the tube that connects the mouth to the stomach. It's a very soft kind of tissue, and it does get a little bit of sort of a sunburn from radiation. As they get towards the last week, sometimes people need to eat a soft diet or milkshakes or something like that. In the head and neck region, if people have radiation there, they can be left with dry mouth, and they have to have good dental care, fluoride, plates or treatments to help prevent cavities that get much more common if they've had radiation to the head and neck and mouth area.
Yes. How do you address pain associated with radiation or areas of spread?
Generally, the pain would be sort of minimal or just from the sore throat, and it's usually sort of manageable without any very formal pain management. But trying to have good mouth care, mouth rinses if the mouth is dry or getting mouth sores, just lightening up on what they're eating. It will heal rather quickly, usually on its own. It's not usually very persistent. Unfortunately, I have noticed nowadays sometimes there are, if a patient had been a little resistant and is being to chemotherapy and is getting a salvage radiation regimen, they will go a little higher and they will get more trouble with mouth soreness, and it'll take longer to heal. Usually rely on a liquid diet, and certainly if they need a painkiller, they can have it, but they're not commonly needed.
How do you know if the treatment's working? How do you know? What do you do?
Well, generally we rely on CAT scans, but more importantly PET scans that were done at the beginning to highlight all the hot spots, so to speak. They're literally hot in terms of the radioactive signal that's coming from the PET agent accumulating there where the fast-growing cells were. And we look after 2 to 4 cycles of chemotherapy. There's been some active debate on this and studies done on this. Historically, we've done it about a little past midway, after 4 cycles or so of chemotherapy, and we're looking to see that PET scan is negative now. The lumps may be still continuing to shrink. If they were 3 inches, they might bound to 1 or 2 inches, but we're not sure, is it completely clear of live lymphoma cells? And the PET agent really gives us a better picture of that. The activity of the PET should be all clear after that midpoint evaluation after a few cycles of chemo. Now there's been a trend towards moving the PET scan a little earlier after 2 cycles. It has to be at least 2 weeks after that second cycle, preferably right before the 3rd dose is due, based on some data out of European studies looking at the quality of prediction of whether someone would relapse if it goes clear earlier on the PET scan. The only caveat there is we haven't particularly proven that there's a point where you should be changing management strictly based on that. What we generally do, in other words, we don't just send someone off to transplant because their PET scan didn't go clear. We usually do 2 more cycles of chemotherapy and check the PET again, and we know to be a little more suspicious in that individual that they're at higher risk for relapse than the person who was all clear after 2 cycles. Also, in some cases, we don't have any visible or palpable lymph nodes that we can see to know that they're responding to therapy. If they're all internal nodes in the abdomen, the only way you can tell if they're responding to chemo is by the scan. And most of us would rather do that before we've already gone, 4 cycles into this. We'd like to have some interim check to say that they're clearly responding. Most people do. I mean, the response rates on R-CHOP are better than 90%. We also want to look at the quality of the response. Is it a sluggish or partial response, or is it a very high-quality response that we hope is going to be a complete remission?
I see. Why don't we move on to stage 3 and 4?
Sure.
So how would the treatment be different for stages 3 and 4 versus stages 1 and 2?
Well, again, most stage 2s are going to be lumped with stage 3 and 4, particularly if they're bulky. But it's generally just the R-CHOP chemotherapy, Rituxan, Cytotoxin, Adriamycin, vincristine, prednisone. for 6 cycles, classically now. It was previously more common to give 8 cycles historically, and also in Europe till more recent times. Large European trials suggest that 6 cycles is about equivalent to 8, although I do want to point out that in the European trials they generally left in the 7th and 8th dose of rituximab. There's a very interesting article in publication in the American Society of Hematology this year, where the German lymphoma study groups assessed whether they had tried to compress the cycle of R-CHOP into 2-week cycles, and that was looked at very extensively in European trials, and some debate on who might benefit from this shortened R-CHOP at 14-day cycles instead of 21. But one of the things they did worry about is that they had shortened the dosing of the Rituxan, and Rituxan is a biologic agent that's meant to stay in your system for months afterwards, and months after the chemo is gone, to continue to have the immune system work on it. So they did a trial they called Smart R-CHOP, or Smarter CHOP, looking at spreading that Rituxan dosing back out, and it did suggest that we should keep that out on a longer schedule and not try to cut corners on the rituximab, likely because we need that biologic effect to help continue out killing off any stray residual cells that are still out there that escape the chemotherapy.
Okay, what if the patient has HIV and diffuse large B-cell lymphoma?
Well, basically, HIV introduces a couple variables here because it affects the immune system as well as the chemotherapy might. First of all, HIV is a big risk factor for developing diffuse large B-cell lymphoma. During the AIDS epidemic, there was a 100 times increased risk of this type of lymphoma. After the advent of effective therapy or heart therapy, that risk dropped dramatically, but not quite to baseline. So some patients will be simultaneously diagnosed with HIV and lymphoma. They didn't know they had the HIV before, and ideally we'd rather have the HIV controlled, their viral load down, they'd be on medication, and their CD4 counts would be up in good range before we started chemotherapy. As long as the HIV is well controlled, the outcomes with HIV lymphomas are still quite good. We've even taken patients through bone marrow transplant with HIV as long as it was well controlled. On the other hand, if their immune system has really been taken down by the HIV and their CD4 counts poor or poorly controlled, they have many more infectious complications, and they typically will have more unusual sites of disease involvement. They'll have more extranodal sites, bone or lung or kidney, and can have more complications of the primary involvement of the lymphoma as well. Drugs themselves are generally treated approximately the same. Generally, R-CHOP or a REPOC type regimen, which is a slightly modified CHOP with etoposide.
I see. So when you finish the 6 cycles, how do you follow the patient afterwards?
In all patients, not just HIV patients, we'll usually follow with CT scans if the PET scan has already gone negative. We used to follow with PET CTs. Many insurance companies won't allow us to do that anymore, and probably is better to reduce some of the radiation exposure. So if a patient had one before treatment, middle of treatment, we'll do one at 6 months, 12 months, 24 months is a typical schedule. Some studies will do them a little more often because they're trying to assess first time of progression, like every 3 months. And we'll often continue the PET scan if there were non-lymph node sites of disease that are only seen by PET, like GI or bone involvement, that was typically seen better by the PET scan itself.
I see. So let's say, God forbid, if the lymphoma does come back, what happens next?
Generally, the approach in a patient who's young enough or well enough to do so would be to pursue a salvage type of chemotherapy. It's usually based on some inpatient chemotherapy regimens like RICE, Rituxan plus ifosfamide carboplatin etoposide, or ESHAP with Rituxan ReSHAP, Rituxan with etoposide, solumedrol, Ara-C, platinum, and consolidate or finish with high-dose chemotherapy and a stem cell transplant, autologous stem cell transplant using the patient's own stem cells that were collected from their own blood after some stimulation with shots of Neupogen to flush those stem cells out of the blood. That's generally a fairly arduous procedure, about 3 weeks in the hospital, a few days of chemotherapy, historically chemo plus radiation, that's not usually done anymore, followed by thawing of those stem cells that were collected from that patient a week or 2 ahead of time, or could be much longer ahead of time, thawed out and reinfused like a blood transfusion. The cells find their way back to the bone marrow and set up shop and start to grow in about a week and a half. During that time, patients usually kept in isolation, need a few transfusions, need some IV antibiotics, feel tired, have mouth sores, get some for very poor appetite. It's a very tiring procedure.
Mm-hmm.
Not usually painful, just very tiring.
What is the odds of cure if someone does have relapsed diffuse large B-cell lymphoma?
Well, it depends on the circumstances a little bit. Someone who had gone into a complete remission before and then relapsed and then responded very well again to their salvage chemotherapy might have historically a 40-50% chance of cure. Nowadays, with the addition of Rituxan, also rituximab, the antibody around the transplant or even after the transplant, seems to bump those rates up into more the 70 or 80% cure range. There are some individuals who never really went into a full remission, or they did not go into complete remission on the second line of chemotherapy, and those refractory or partly refractory patients generally don't do so well from the transplants. The cure rates are much lower. In fact, if they're really significantly resistant to chemotherapy, they're usually not offered a standard autologous transplant. The outcomes are too poor. Folks have tried other approaches. Those are still considered experimental, like using the radioactive antibodies plus the chemo regimen of the transplant. And those are sort of interesting, but still being studied.
Okay. Well, thank you so much.
You're very welcome.
Thank you for watching. We hope this has been educational for you as well.